in the ER, and I currently work at Westfields Hospital in the ER, and then I do part-time ER education for Westfields. And I also work at Northwood Technical College as a nursing instructor. And prior to nursing, I was in EMS as an EMT and paramedic as well. So I've been around healthcare for over 20 years now. So yeah, excited to be here and kind of geek out and teach you a little bit about sepsis today, and just kind of some things about what to watch for, what to look for when you're doing your assessment, and then interventions too. So welcome everybody. All right. Just gonna share my screen. All right, can you guys all see?
Looks good, Erin.
Okay, perfect. All right, so we're gonna dive into sepsis, and you could just unmute yourself if you want. Are people primarily in the hospital, or are there pre-hospital people here with us? Can you just share a little bit?
Pre-hospital.
Okay, fantastic. Okay, hospital, pre-hospital. All right, great. So I will try and touch on a little bit of everything. And if you have questions about maybe some things that you could be doing pre-hospital, I will cover that. If you have any other questions, let me know. We're going to cover a little bit about sepsis and just like basic pathophys. We're not going to dive into that very much. I really want to kind of focus on assessment, diagnostics, and some interventions. So we'll dive into sepsis. So what is sepsis? Okay, so sepsis is just like this huge, extensive physiological and biochemical response. It happens when your body has kind of this overwhelming and life-threatening reaction to an infection. It leads to potentially some pretty serious organ damage and death. It is a form of distributive shock. So if you think about the different shock states in terms of distributive, hypovolemic, cardiogenic, it is a form of distributive shock that can lead to some pretty severe organ dysfunction. Most of the time, sepsis is caused by gram-negative and gram-positive organisms, and I'll talk a little bit later about which ones those are, but most of the time it's Klebsiella, staph, strep, E. coli, but it certainly could be caused by a pretty bad viral infection or a fungal infection, but most of the time it's those gram-negative and gram-positive bacteria. Just to kind of give you an idea of severity, in terms of prevalence for sepsis, every year 1.7 million people in the US develop sepsis, and approximately 50 million people worldwide. So it's very prevalent. Whether we recognize it right away or not, it's very prevalent. And sepsis is also responsible for approximately 11 million deaths worldwide each year. And then when you think about like patients that we bring into the hospital, or patients that get admitted to our ICUs, sepsis is the #1 cause of death in the hospitals, the #1 cause of readmission in hospitals, and the #1 healthcare cost disease process or disease that patients present with in the hospital. So it's a pretty big problem, and we have the unique opportunity, I would say, to recognize it and then try and treat it too. All right, so let's just briefly talk about pathophysiology of sepsis. And I kind of made this little chart for you, and I'm going to kind of just break down a little bit each of the different steps to kind of go through it and just talk a little bit about more in depth. So overall, just kind of an umbrella statement, sepsis leads to profound cellular, circulatory, and metabolic abnormalities. And I'm going to break those down in just a second. Ultimately, if we don't intervene, we don't recognize that the patient is septic, it can lead to circulatory collapse with persistent hypotension despite us giving them adequate tissue perfusion. So we really have to recognize that they're septic, and we have to act quickly, and we'll talk about that in a second. So how does sepsis work? Well, you have your invading microorganisms. So that's like your bacteria or your fungi or whatever. That's your invading microorganism. So that invades the body. Once that happens, it sets off this cascade of immune and inflammatory response. Okay, so then neutrophils and macrophages get sent to the site of the infection. As soon as that inflammatory and immune response kicks in, endotoxins are going to get released into the body and stimulate the release of cytokines. This is going to cause an increased immune and inflammatory response. It's also going to cause damage to our vessels. This is why we start having like leakiness of our vessels, because we have this increased capillary permeability. So what happens then? Our vessels are going to dilate. We're going to get hypotensive, right? Because all these things are going to be leaking out of where they should be in terms of, vessels should stay open, fluid should be moving around the body. When we have this increased capillary permeability, the vessels are going to leak, everything is going to vasodilate, and we're going to have changes in our fluid volume. We're also going to have endothelial damage, so damage to the actual vessel itself. This is going to cause increased leaking. It's also going to cause clotting. One of our main things that we want to worry about with sepsis is the development of clots. Sepsis is considered a hypercoagulable state, and we're going to talk about how we can treat that in a little bit. But be mindful of the fact that your patient can develop clots. Coagulation is going to increase, so platelets are going to increase, and we're going to try and coagulate and clot. One of the bad side effects of sepsis too is that our fibrin is actually going to decrease. So there is a risk for patients to actually develop DIC, or disseminated intravascular coagulopathy, where you're going to have this mismatch of the body's going to try and bleed and they're going to try and clot. But as it continues to go through DIC, the bleeding isn't going to be able to keep up with the clotting. And so there's going to be a huge problem there. All of the above problems listed on the slide are going to lead to an increase in oxygen demand with a limited supply. So eventually, the body is going to activate the CNS and the endocrine system. It's going to go into this hypermetabolic state, which the cells then are going to have an increase in oxygen demand and a decrease in tissue perfusion, and the body's not going to be able to keep up with the oxygen demand. So the patient's going to get hypoxic. The cells are going to get hypoxic. And when the cells get hypoxic, we're going to develop lactic acid, which we're going to talk about in a little bit. But all of this is going to increase our oxygen demand with very little supply. So what are you going to see in your patient? You're going to see decreased cellular oxygen. The patient's going to become hypoxic. They're going to have ineffective tissue perfusion. So you're going to notice things like hypotension, tachycardia, and then impaired cellular metabolism too. You're going to notice changes in their blood sugar. All of these problems are going to lead to organ dysfunction. All right, I know that was a lot, but it's just kind of an overview of pathophysiology. All right, stages of sepsis. So there's kind of 4 stages of sepsis. The initial stage is going to begin at the cellular level. So cellular metabolism is going to change from aerobic to anaerobic, and when that happens, lactic acid is going to develop. In the initial stage, this is where we can kind of miss things a little bit, because symptoms are not always going to be clinically present in your patient, okay? Then it's going to move on to a compensatory stage. So the body's going to activate this neural, hormonal, and biochemical mechanisms to try and overcome that anaerobic metabolism. Early shock will set in, and this is where you're going to start to see your patient become symptomatic. So the patient will start to show signs of increased oxygen demand and supply, decreased cardiac output. You're going to see a narrowed pulse pressure if you're taking frequent vital signs and frequent blood pressures. The SNS will try and compensate by trying to vasoconstrict to increase blood pressure. So you, again, might notice some fluctuations in your blood pressure. Your tachycardia might increase a little bit. And again, it's all part of the body trying to compensate for those vessels that are changing and oxygen demand that's increasing. The body is also going to try and release some intrinsic vasoconstrictors, which would be our epi, norepi. Heart rate will increase because of that, and your respiratory rate will increase. You may or may not notice some neuro changes at this point. I always tell my students the first stop on the oxygen train is the brain. So if we're starting to have some alterations in oxygen demand, we might certainly notice some neuro changes happening at this point. Blood is going to start to shunt to the vital organs, which means you're going to start to see some changes. You might not notice it pre-hospital, but you might notice it in your patient in the hospital, or if they're in the ER for a few hours or something. You might notice that blood shunting because you might notice things like GIGU is going to kind of slow down or stop. So you might notice urine output is going to decrease, or you know, if the septic infection has been going on potentially for a little bit of time, patients might say, oh, I haven't had to have a bowel movement in a little while. Eventually, it can turn into acute kidney injury and some bowel ischemia because blood is kind of being shunted away from the GIGU system and more towards the vital organs. As it progresses to the progressive stage, this is where we really need to intervene, or the patient will go into MODS, which is multi-organ dysfunction syndrome. So in the progressive stage, all of our compensatory mechanisms are going to fail. The patient's going to go into septic shock, excuse me. You're really going to notice altered mental status. That's when you're going to notice that profound hypotension, tachycardia, tachypnea. We're going to talk a little bit about fever. That's going to go with that metabolic state. We'll talk about that in a second. But in the progressive stage, you know, your patient can only go for a while before they start to peter out, right? So cardiac and respiratory systems are going to begin to fail. And that's when you're really going to have a severe decrease in cardiac output, decreased perfusion. The patient is going to become edematous, especially out in the periphery because of those leaky vessels. Fluid shifts may or may not occur. I mean, you're going to have the leaky vessels, so they're going to be edematous out in the periphery, which is going to make it really hard to get that blood back or the fluid back into the vessel to help support cardiac output. They're going to have hypotension, like I said, tachycardia, tachypnea. They could have dysrhythmias. It may be enough of a strain on the heart that some of them will actually have myocardial ischemia, possible MI, certainly respiratory distress, pulmonary hypertension, ARDS could be a possibility, and then certainly we're going to see that acute kidney injury. So again, progressive state, I mean, we really want to jump in the compensatory states, but that progressive stage, we also want to jump into, otherwise it's going to be just too far gone at that point. They're going to progress into MODS. All right, last is the refractory stage. So recovery is pretty unlikely in the refractory stage. In the refractory stage, there's going to be decreased perfusion from massive vasoconstriction and decreased cardiac output. Cardiac output is going to worsen, anaerobic metabolism is going to worsen, so you're going to have increased lactic acid buildup. You're going to have that increased capillary permeability and dilation. So again, everything is going to leak out, and you're going to have profound hypotension, massive edema, respiratory collapse, altered mental status. They probably will not be with it at all. You know, could be unresponsive even. GIGU systems are going to fail due to lack of blood flow, and everything is just going to shut down. All right. I know it's a lot. So any questions so far? All right. So let's look at some risk factors for sepsis. So your risk factors, and a lot of these we see already, right? If someone has an infection, we should automatically be thinking, ooh, are they at risk for developing sepsis? Most likely, yes. So let's look at some risk factors, and we're going to hit on some other things too that are not infectious in just a second. So risk factors, so patients who have had a recent or ongoing infection, things like pneumonia, or they've had a UTI or peritonitis, those would be, certainly our biggest risk factors when you're thinking about infections that are going to cause sepsis. Other patients that are at risk, anyone with an indwelling catheter or a central line. So patients that maybe are getting treatment for their infection, but they have a PICC line in place, or they have a portacath in place, or they have some other central line that has the risk of developing an infection. Even with our best, wearing gloves, wearing sterile gloves, doing sterile procedures, we certainly are putting the patient at risk every time we access them or use them. So those patients are always at risk for developing sepsis. Other population or people that are at risk, certain populations like are really young, you think about newborns, infants, and then our elderly patients, especially if they have comorbidities like diabetes, heart failure, COPD, anyone who's malnourished, anyone who is potentially immunocompromised. We think about like our oncology patients, our transplant patients. When you look at comorbidities, patients with kidney disease, liver disease, they would also be at risk. Patients who've had major surgery, trauma, burns. The list just kind of goes on and on. If you think they could potentially be a risk for sepsis, they probably are a risk for sepsis. All right. So we kind of talked about the different stages of sepsis, but let's look at sepsis complications. I kind of briefly hit on this a little bit, but let's dive into it a little bit more. Septic shock, this is going to occur when we get that profound hypertension, or excuse me, hypotension. We've noticed those changes in vital signs. They become hypovolemic. That certainly can happen, and it can happen very quickly. If a patient develops an infection, septic shock can actually occur very quickly within a few hours of this kind of systemic response that's happening to sepsis. Other complications, once the patient goes from septic shock, they can go into SIRS, which is systemic inflammatory response syndrome. They typically go hand in hand, but it's certainly a complication. And then we talked about MODS, that multiple organ dysfunction syndrome. Just a little tidbit of information for you. Approximately 60% of patients die once they develop circulatory or cellular or metabolic abnormalities related to sepsis. I'm going to give you another statistic a little bit later, but just kind of keep that in mind. Other complications of sepsis, ARDS, we talked about acute kidney injury, so acute and chronic renal failure are also some complications that can occur. DIC, like we talked about, mesenteric ischemia, especially in the bowel, once that blood starts to shunt, acute liver failure, and then we talked about myocardial failure too, possible MI. So lots of complications. We really, really, really want to intervene as soon as possible. All right. SIRS criteria. If we have a patient that we suspect has sepsis, we can kind of quickly identify in our assessments if they're meeting some SIRS criteria. Now, I will say, be very mindful of their clinical presentation. If you have a patient who potentially is having an anxiety attack, they're potentially going to be tachycardic and tachypneic. So be mindful of their clinical presentation. Okay, so let's look at the SIRS criteria. In order for the patient to potentially be septic, we want to have at least 2 or more positive SIRS criteria. So when we start looking at vital signs, the patient is likely going to be tachycardic, and we say greater than 90 beats per minute. Some will say 100, greater than 100. Okay, so greater than 90 on tachycardia. Hypotension, the systolic blood pressure is going to be less than 100, and the MAP will be below 70. And that's a sustained hypotension, right? It's not just one value. One value means nothing. So at least get a couple of different blood pressures. They're going to be tachypnic, greater than 22, hyper or hypothermia. Okay, so hyperthermia greater than 100.9 Fahrenheit or hypothermia. And I will tell you, just from my experience, some of the worst septic patients that I've ever seen have been hypothermic, right? Because the metabolic state, if you think about fever, right? Our body is going to increase our fever to help fight off that infection. Once our body is not able to regulate our fever, we're kind of losing some of those defense mechanisms to fight off infection. And so, like I said, some of the worst patients, septic patients I have seen, they've been hypothermic to the point where I've done rectal temps on them. And I had to double check and get a second rectal thermometer because I could not believe how hypothermic they were. So if you are at all concerned that the patient is hypothermic, make sure to really get a good rectal temp and make sure it's working and all the things. Oxygen saturation will be less than 92% on room air, and that's for a patient who does not have known lung disease. So like your COPDer isn't going to be in that mix, right? So this is a patient without known lung disease who's got an O2 sat of less than 92%. Hyperglycemic, greater than 140 in the non-eating, non-diabetic patient. Again, this is going to go with your hypermetabolic state, right? Your body is going to try and increase that metabolic process to kind of help fight off this inflammatory and infectious response. So a little bit of stress hyperglycemia, because our cortisol levels are going to rise during inflammation and infection, which is going to increase our blood sugar. So a little bit of blood sugar elevation is okay, and it's probably not a bad thing. But if it's really high, that's too high, and we're going to potentially need to treat with a little bit of insulin. Now, on the flip side, we certainly don't want them to be low, right? And you're going to have to treat that too. And then looking at your white blood cells, are they going to be low or high? Typically in a bacterial infection, we're going to see those elevated WBC numbers. Viral, you might see a normal or a low WBC number. So be mindful of that. And certainly pre-hospital, you're not going to see those white blood cell numbers, but you should be able to measure everything else. Okay. And again, we want 2 or more positive SIRS criteria to potentially think that they're septic. So when you're thinking about these vital signs, give me some examples of where you might see elevation in these vital signs, but it might not fit the clinical picture. So I gave you an example of a person who's having an anxiety attack. Give me some other examples where it probably won't fit the sepsis criteria, but they're going to trip 2 or more of these abnormalities. Throw them in the chat. AFib with RVR, yep. Any sort of dysrhythmia could set that off. Yeah. What else? Drug use. I think of things like an asthma attack. We talked about anxiety, any dysrhythmias. A person having a STEMI could potentially meet some of these SIRS criteria, right? So when you're thinking about SIRS criteria. When I worked at the U, we actually had this best practice or BPA advisory that would fire on us when we put in the triage vital signs. And it would say, hey, your patient has tripped 2 SIRS criteria. Is there a chance of infection? And so you have to use your clinical judgment a little bit to kind of decide, hey, is this person potentially have an infection, or is there some other disease process or disease state that's going on? And if they did have risk for infection, it would trip and say, hey, let's start treating this. Let's start ordering some fluids. Let's do some antibiotics versus the clinical picture doesn't really fit, you know? So use your clinical judgment, but just keep in mind the SIRS criteria is a quick and easy way, once you get your vital signs, to help you determine, is this patient potentially septic or not? Vital signs are super easy. Everyone has access to them, right? You can assess that pretty easily, pre-hospital or ER. Let's look at a few other sepsis assessment findings. So when we talked about tachycardia and hypotension, just keep in mind any other symptoms that could potentially cause decreased cardiac output, okay? So how would that manifest? Neuro, like I said, the first stop on the oxygen train is the brain. So any changes in mental status, are they less responsive to you? Are they unresponsive? Are they agitated and restless? That can be an early sign. You know, with confusion, those could be some earlier signs that maybe they're not getting a lot of oxygen. Respiratory, you know, if you're worried about potentially staph, strep, those kinds of things, are they having any abnormal lung sounds? Do you hear crackles? Is there wheezing going on? Are they hypoxic? You know, and again, are they having some neuro changes with that hypoxia? Are you noticing skin color changes? Are they in respiratory failure? Do they have some pulmonary hypertension going on? You probably wouldn't know that pre-hospital necessarily, but certainly if they have a history of it, that could be a concern. Skin, what does their skin look like? If they have a fever, are they warm and flushed, or are they kind of cool and mottled, which could be a late sign, which is really cluing you in that they've got some hypotension and decreased cardiac output going on. And then, like we talked about earlier, the GIGU, decreased urine output. Could they potentially have an ileus if things aren't moving through properly? Is there some GI bleeding going on? So, you know, be mindful of these other body systems too that could be affected by sepsis. All right, so one key takeaway, sepsis is all about time. So we're going to talk about recognition and, you know, getting our labs, getting our fluids going, getting antibiotics going. But I think this statistic is really important. The risk of death from sepsis increases by as much as 8% for every hour that treatment is delayed. So it really doesn't take long for once sepsis to kick in that this patient is going to be pretty severely sick, and we need to really intervene before things get pretty bad. It won't take very long. All right, how do we diagnose sepsis? Well, SIRS criteria is going to kind of give us a little clue, right? But to really truly diagnose this, we need to do some other things. When we look at labs, you want to look at a CBC, right? That's going to give us our white blood cells, red blood cells, platelets, and then all of our differential. So in our CBC, is our white blood cells going to be high? Is it going to be low? And then we want to check our platelets too, and then certainly red blood cells. And we'll talk about this in a little bit later, but if a hemoglobin is below 7, we'll consider some blood transfusion, but we'll talk about that in a little bit. Comprehensive metabolic panel or basic metabolic panel. Comprehensive is probably more appropriate. It's going to give you those extra kidney and liver diagnostics, where the basic isn't really going to have the liver function tests on there. You want to look for the elevated glucose. Lactate, that is our gold standard in diagnosing sepsis, lactate. A normal is below 2, but once it's greater than 2 and really greater than 4, we're highly suspicious. We want to look at the base deficit, and that'll kind of get into ABGs. Getting an ABG would be great, which is an arterial blood gas. You can get venous, but arterial would be better. So then really looking at, are they acidosis or alkalosis? Blood and urine cultures, they're probably going to be positive. It's important to get them, but it's not going to help us. It's not going to delay treatment for us. And if you're going to get a blood culture, always, always, always get one off. If they have a central line, get a culture off that line. Get a culture off the urinary catheter if you can. Get a culture off their port for sure. Get one set off of there. Inflammatory markers, so things like a CRP, a procalcitonin could be ordered as well, just to kind of look at inflammatory markers. And then urine. Get a UA, get a UC. Let's look at those electrolytes and then check the specific gravity too. Other diagnostics to consider if we know the patient has a pneumonia, a chest x-ray or a CT of the chest and abdomen could be appropriate. And then other imaging studies based on the presentation of the patient would be appropriate. But lactate here is our gold standard. Got to get that lactate. All right, in terms of sepsis treatment. So the Society of Critical Care Medicine actually put out this last year. It used to be that there was a 1-hour bundle and a 3-hour bundle. And based on the research that I read recently, they're really trying to push for just a all-encompassing 1-hour bundle. So the first thing we should do, recognize that the patient is septic. Then establish 2 large bore IVs, draw labs. Okay, and I always say 1 IV is good, 2 is better, and I'll talk about why 2 is better in a little bit. But get those IVs started and draw those labs. Get your cultures, get all your blood work, and get that lactate. The goal used to be that lactate was drawn within 30 minutes. I say as soon as you can get an IV started and get that lactate drawn, the better. Lactate needs to go on ice and then get to the lab and get that drawn right away. Get your blood cultures, but do not delay antibiotics. Get those cultures drawn and cooking, but then you're going to start broad spectrum antibiotics. And then we're going to do rapid administration of a crystalloid. Usually it's going to be normal saline or lactated ringers, and we're going to talk about lactated ringers and why we might want to be a little cautious with that, but it's going to be 30 milligrams per kilogram. And that is the patient's body weight, not ideal body weight, but the actual patient's body weight on that one. And then if they're not responding and they're still hypotensive after your crystalloid, then you're going to consider adding a vasopressor. And we're going to get into this in just a little bit, but I like the graphic. I'm a visual person. All right, so that's the recommendation within that first hour. Get it going. All righty. So let's break this down a little bit farther in terms of treatment. When I was at the U, we actually had a code sepsis, and if is anyone familiar with the U, you kind of know that they're weird patients. Like they just they're pretty sick folks, but they're weird blood disorders, right? So lots of blood disorders, lots of organ transplant patients. Like the people there are kind of sick. So we developed this code sepsis because we noticed that our antibiotic times were actually pretty slow and we were not meeting the 1 and 3 hour bundle. So we wanted to develop this code to kind of just get more patients, like everybody loves a good code, right? Like, I don't know about all of you, but the adrenaline junkie in me loves a good code, right? It's like, ooh, what are they bringing in? So like we wanted to bring the excitement and raise awareness to the severity of these patients, and we developed it into a code sepsis. The code sepsis just really brings more resources to the bedside to help rapidly assess the patient and start treatment. So I think it's super important that you make this just as important as like a STEMI patient or a stroke patient, because they really are that sick and they really deserve to, have really good resources and access brought to them so you can start treatment right away. I mean, this is a critical patient. All right, so when we think about sepsis and treatment, triage the patient in a timely manner, identify that they're septic. If they're pre-hospital, if you're going on this call and they tell you when you're doing your assessment, hey, I've been sick for the last few days, or hey, I have pneumonia, or, you know, I recently had this surgery, always be thinking of those SIRS criteria. And again, correlate with that, the clinical picture. You really want to identify the fact that this patient is sick. If they're in the hospital, you really want to get a doctor to see them within, you know, 10, 15 minutes tops. And then initiate that code sepsis or initiate your standing orders. And that goes pre-hospital or in the hospital. Initiate those standing orders. If you feel like the patient is sick, use your clinical judgment and initiate those standing orders. When we think about resuscitating these patients, support their ABCs. So when I talk about support ABCs, if they're hypoxic, make sure they're on oxygen. If they are unresponsive, consider, you know, everyone deserves a good airway. So consider that, you know, you may need to intubate and that's okay. Oxygen therapy, do they need a central line? They might need a central line if you're going to be running vasopressors for a while. You know, do they need ICP monitoring? Do they need other lines like urinary catheters or anything like that to help you measure these things? And typically the oxygen goal is going to be between 90 and 96%. So you definitely want to just support them if they're hypoxic. Start 2 IVs. I always say 1 IV is good, 2 is better. 2 IVs is a good idea. 1, because you're going to be drawing a ton of labs. So you probably want one a little bit free for that, especially if you're going to be repeating labs frequently. You're going to be running a massive amount of fluids. The other thing is if the patient is not responding to fluids, you're going to start a vasopressor. And that vasopressor should probably run by itself. You can link it in with your fluids, but it should run by itself. The other thing is if you're going to start a vasopressor, you really should consider a central line. It can run peripherally for a couple of hours, but you should consider a central line at some point. So I always say 1 line is good, 2 is better. You're going to be giving this patient a lot of medications. So having multiple lines is a good idea, but you know, get what you can get. The other thing to consider too is once you start doing antibiotics and pressors, you're going to have maybe a pressor on one side and an antibiotic on the other. It's a good idea to have multiple lines. And just for, you know, just thinking about resuscitative reasons, it's just a good idea to have multiple sites of access. So just consider that. When you start your large bore IVs, make sure to draw your labs. Start your fluids, 30 mils per kilogram. And again, that's the patient's weight, not ideal weight. And then if they are still hypotensive despite fluid resuscitation, so let's say, you know, most patients will get between 1 and 3 liters of a normal saline or lactated ringers. If they're still hypotensive after you've given those fluids, you're going to consider a vasopressor. And levofed or norepinephrine is your go-to vasopressor. Dopamine can be considered too, but levofed's kind of the standard. But just make sure, right? You know, the old adage was levofed leaves them dead. So if you start levofed, you need to, and you want to squeeze that pump, you really got to make sure that you have adequate fluids in the pump for the pump to work. Otherwise, you're going to be in a world of hurt with levofed if you don't have adequate fluid resuscitation. And the goal for that is a map of 65 to 70. And then we want to get those broad spectrum antibiotics going. When we talk about gram-negative and gram-positive bacteria, your most common ones, again, are E. coli, Klebsiella, staph, strep. So most of the time, and MRSA could be a consideration here. So when you think about broad spectrum antibiotics, usually vancomycin is going to be chosen. Other ones, it's pretty common to see Zosyn and vancomycin. You could also see things like ceftriaxone, cefepines, meropenem, potentially some antifungals. But I would say most of the time it's Zosyn and vancomycin. And the nice thing is too is it buys you a little bit of time. You can run that Zosyn over 30 minutes, and then the vanco is typically going to be weight-based and brought in by pharmacy. And so you get that Zosyn going right away, run it over 30 minutes, and then start your vanco. Once you kind of resuscitate the patient, then you really want to dive into what the cause is. So review those labs, consider some imaging, figure out what the source of the infection is, reassess all of your interventions, and you're doing this continuously anyways. Consider nutritional therapy due to that hypermetabolic state. So the glucose, we want a little bit of glucose, right, to feed those cells, because our cells need oxygen and sugar. We want a little bit of glucose to feed the cells, but we want to keep that blood sugar below 180. Other things to consider if this patient is going to be NPO and, really the stress of this whole process, consider a PPI like a Protonix for stress ulcer prophylaxis. We talked about how sepsis can be a hypercoagulable state, risk for clots, so consider DVT prophylaxis. Most of the time, heparin and Lovenox are appropriate and usually what I've seen. And then consider steroids if the vasopressor is not helpful. Steroids are pretty controversial. They don't really know the mechanism. They don't know if it's helpful. The only time I've really seen it in practice is when the vasopressor is not working and it's kind of like, let's just throw everything at the wall. It used to be part of like a bundle with treatment, but it's not so much anymore, but it is something that it's questionable. Does it work? Does it not work? We don't know. Something to consider. And then disposition. So if you're pre-hospital or ER, or if you're in a critical access place, or if you're at, Regions or Hennepin or whatever, think about the disposition. Can this patient be managed in-house, or do they need to transfer somewhere? If they're sick, do we need to call critical care transport? Do we need to call a helicopter? How fast can we drive, kind of thing? Is the patient getting better or worse with your treatment? Do you need to kind of change your interventions? And then really think about, does this patient need surgical intervention? Do they need to just go to the ICU? Really think about where the best place is for your patient and then make sure that you get them there. All right, questions at all on treatment and diagnosis? I know it's a lot. So we're going to practice. I want you to use the chat, and we're going to do some review questions and see how much you learned and maybe some things that you picked up on. All right, so here is your first question. Question number 1. Sepsis causes system-wide vasodilation, which leads to an increase in systemic vascular resistance. In addition, septic shock causes increased capillary permeability and clot formation in the microcirculation throughout the body. True or false? Yeah, very good. True. True. All right, number 2. You're providing care to 4 patients. I'm sorry. Hold on one second. All right, so the question should read, I copied this, I apologize. The question should read, what type of shock is septic shock? What kind of shock is it? Cardiogenic, anaphylactic, distributive, or hypovolemic? What type of shock is sepsis? Yeah, my apologies. Sepsis is distributive shock, so distributive. I copied and pasted, so I'm sorry, guys. All right, question number 3. You're caring for 4 patients. Which one is most likely to develop sepsis? Yeah, I mean, they're all kind of a hot mess, right? But A definitely is probably our most at risk for developing sepsis. So renal insufficiency, our kidneys are already not working, has a Foley catheter, that's another source of potential infection, and a central line, a third source of potential infection there. So A is probably our most likely to develop sepsis. Okay, number 4, name 2 SIRS criteria. Give me 2 SIRS criteria. They can be any 2. Ooh, Angela, very good. You get a whole bunch of them. All right, awesome. Yeah. So our SIRS criteria as a review, right? We've got our tachycardia, tachypnea. They can be high or low on our temperature, hypotension. Our blood sugar is going to be elevated. Our white blood cells are going to be elevated, right? So looking out for those SIRS criteria when you're doing that initial first triage, initial first assessment. Good. All right, question number 5. 1 IV is good, blank is better. One of the things I say all the time to my students. Yeah, 2. 1 IV is good, 2 is better. Very good. All right. Number 6, name 3 labs that you would draw if you suspect your patient has sepsis. Three different labs. Yeah. And what is our gold standard lab to help us kind of diagnose the sepsis? What's our gold standard? Lactic. Yeah, John, awesome. You're on it. So yeah, some labs that you would consider drawing, CBC for sure. Get that CMP. I like a good comprehensive metabolic panel if I had to choose between a CMP and a BMP, to be quite honest. A liver panel, got to get that lactic. Lactic is our gold standard. Get that green on ice, get it over to the lab ASAP. Consider your inflammatory studies like your CMP, your ProCal. Get those blood cultures, get those urine cultures, get your coagulation studies, get a D-dimer, right? We want those coags to see if that patient's already, what's their bleeding time? Are we clotting? Is the D-dimer elevated? So get all the things. All right. Number 7, a patient in septic shock receives 2 liters of normal saline IV fluids. However, this was unsuccessful in maintaining tissue perfusion. As the nurse, you would anticipate the physician to order what next? Yeah, a pressor, right? So they've gotten 2 liters. I mean, you could say, like, right, if we're going to consider, is that enough to meet the 30 mLs per kilogram? Maybe we're going to give a little more fluids, but really, if they're unsuccessful at maintaining tissue perfusion, they're still hypotensive after they get the fluids. Next up is a vasopressor, and norepi is our go-to. All right, good. Question 8. So a septic patient's experiencing hyperglycemia. What is the glucose goal? Awesome. Yeah, a little bit of blood sugar is good, right? We want to feed the cells, but too high is no bueno. So less than 180 is the glucose goal. Okay. Number 9, I should wait for blood culture results to start antibiotics. True or false? False. Yeah, get those cultures. Get a peripheral IV started, get a culture off of there. If they've got a central line or a urinary catheter or something, get a culture off of that, but do not delay starting antibiotics to get those culture results. Some of them it's going to take 4 hours, some of it's going to take 3 days. So get it going right away. Last question. As your patient recovers, name 2 measurements that can be monitored to assess organ perfusion. Think about the brain, the kidneys, cardiac. Give me 2 things that you can measure to monitor organ perfusion. I love it, John. You're on it. Awesome, Carrie. Good job. Yeah, so if we think about the brain, right? The first stop on the oxygen train is the brain. So are they mentating? Right? If they're if we're titrating those pressors, are they mentating? Are they feeling a little bit better? Are they able to communicate with us? Kidneys, what's the urine output look like? Cardiac, right? Did we potentially have some arrhythmias and now those are stabilizing? Other things to measure, those ongoing ABGs, the ongoing labs, we're repeating the lactate, reassessing our vital signs after we're doing all these fluids. Any of these things can be monitored to help us assess organ perfusion. All right. So just a quick review, sepsis is a medical emergency. So identify the patient as septic. What is the clinical picture? Does it fit? You know, recognizing those SIRS criteria, initiate a code sepsis if you want, get that extra support to the patient, make sure that, you know, someone is getting those IVs started, get those the labs drawn, support their ABCs if you need to. If that lactate is elevated and it fits the clinical picture, start fluid resuscitation. If they're hypotensive after fluids, start a pressor. Don't wait for cultures, get your antibiotics going, and then really just manage any ongoing symptoms. All right. References. Any questions at all? I know it was a lot.